Right, okay, I'll leave the poll in place for another minute or so, because more and more people usually do arrive in the first minute or so. But welcome everyone today to our latest ScHARR mini masterclass. Just before we start the webinar today, I'm just going to go through a bit of practical information and a few things that you need to know. First of all, the presenters that we have today, I think, are both involved in our master's program in health economics and decision modelling. It's one of several postgraduate programs that we run here at ScHARR. If you want to learn more about the health economics and decision modelling course or our program in public health, you can find that at the links on this slide, and I'll post those into the chat box once the presentation has started. And we're also on Facebook, so if you want to find out a little bit more about ScHARR generally, what we do in both in terms of our teaching and our research, you can find out more there. We also run short courses. We have some of these running over the summer in 2021 and into the autumn, and you can find a bit more about some of our short courses on our short courses webpage. Again, I will put the link to that in the chat once the presentation has started. The last mini masterclass of the 2020-21 academic year is going to be in July. So that's going to be with Dr. Emily Wood, and that will be about supporting a mentally healthy NHS workforce. So you can book for that at the link on the screen, and I think Andy's posting things into the chat as we speak. So that will be our last one for the 2020-2021 academic year, but we will be back in October 2021 with our new programme, and we have speakers booked for all of the 2021 to 2022 academic year, so there'll be plenty more mini masterclasses to come. In terms of practicalities for today, a lot of you seem to be new today, so I'll just run through a few basics of Blackboard Collaborate. So the main thing that most of you will use during the session is the chat, and a few of you have posted to that already. But in terms of how you access the chat, you should probably in the bottom right-hand corner of your screen have a purple tab like that. If you click on it, a white panel will open up, and from there you can access the chat box through the little speech bubble, and you'll probably find that you can view a list of attendees, and you can also access your settings. So for the chat box, you just click on the speech bubble, and then at the bottom of the white panel, there's a box where you can type in questions and comments and communicate with the other participants if you want to. And in the settings cog, there's some stuff in there where you can change your audio and video settings. So if you are having any issues with audio in particular, you can go into the settings to just check that you've got the correct microphone audio output and so on and so forth. Probably at the middle bottom of your screen, or it might be at the top if you're on a mobile device, you have icons for microphone, video, and raise hand. So if you do want to ask a question and you want to do it using your microphone rather than typing into the chat box, you're welcome to do that. You just need to click on your microphone to activate it. And similarly, if you've got a webcam and you want to switch that on so that we can see you, you can activate that with the video button. But we take questions at the end of the presentation, so we'll let Donna and Phil run through their slides, and then at the end of the session we'll open up to questions. So if you want to ask a question in person, so to speak, we'll do that at the end. Any questions that occur to you as we're going through the presentation, you can put questions in the chat at any point in time that you want to, but again we'll come to them at the end. So questions can go into the chat at any point during the presentation, but we'll come to them at the end. And if you do post a question, if you can put Q in front of it, just to make clear that it's a question that you would like the speakers to respond to. What we find is that there's often a bit of chat between participants in the chat box during the session, and that's fine, and it's fine to sort of discuss things between yourselves a little bit if you want to, or just like I say, just make comments rather than questions, but it just makes it a bit easier in terms of moderating the questions at the end if we can see clearly which ones are questions that you want us to put to the speaker. So if you can put a Q in front of your question, that would would be great. And then we have the raise hand button. That might be useful if you need our help in any way. If you are having problems with audio or something, or you can't hear us at any time, you can click the raise hand button and one of us will try and contact you, probably via the chat, to see how we can help. So I think that's everything you need to know in terms of how it's all going to run today and how to interact with the platform. So our speakers today are Philip Powell and Donna Rowen. So I'm just going to tell you a little bit more about both of them. Donna is a health economist and has been at ScHARR and within the Health Economics and Decision Science section of ScHARR since 2006. And prior to that, she was a teaching assistant at the University of Sheffield in the economics department, where she was also undertaking her PhD. Her research interests are in measuring and valuing health and quality of life, modelling preference data, methodology of developing preference-based measures of health from existing measures, mapping between measures to generate utility values, and measuring and valuing child health, which is obviously what we're here to hear about today. Philip Powell is a research fellow and a chartered psychologist. He's been with ScHARR since November 2017 and is part of the ScHARR Outcomes Group on measuring and valuing health-related quality of life. And he also has a PhD from the University of Sheffield. His research interests are in measuring and valuing health and quality of life, developing and evaluating patient-reported outcome measures, also known as PROMs, assessing quality of life in children in rare conditions, and the role of emotions and emotion regulation in health. So at this point, I will just switch over the slides to Donna and Phil's presentation, and then I should be able to hand over to them. Is that okay?
Yeah, fantastic. Thanks very much, Claire. So on behalf of Donna and myself, we're very happy to be here delivering this masterclass. And as has been pointed out in the introduction, so I'm a psychologist by background and Donna's an economist. So we work together on lots of different projects, and Donna normally specialises more in the valuation sort of side of things, and I'm more in the theoretical measurement side of things. And so together we sort of make a quite good team, and that's why we've decided to deliver the masterclass as a duo. So we're going to talk for about 40 minutes, and then we're very happy to take questions and comments at the end. So the outline of what we're going to be covering today. So we're really going to be taking these two key things together. So we're going to be looking at what we mean by measuring health in children and adolescents, and particularly around subjective health. So the use of questionnaires, how we use them, how we select them, and how we then move forward to develop them in particular populations. And then I'll be talking around the challenges and issues that are specific to measuring health for children and adolescents that may not arise when we're measuring health for adults, or may be specific to children. And after that, I'm going to hand over to Donna, who's going to talk more around the valuation side of things, the economic part of it, and how we use essentially the questionnaire data and how we convert it and make it usable in an economic framework. So for the evaluation, the economic cost effectiveness analysis of particular health interventions or technologies. And she's going to go through what we mean by valuing and why we do it and why it's important. And also, again, what are the specific things we need to think about and the challenges when we move into the space of valuing health for children and adolescents. So just to start with some input into the measuring of health. So the first thing to say is when we talk about measuring health, at least in this talk, we're really talking about putting a number on health or health-related quality of life. We're not really looking at objective measures here. So this is a subjective measurement of health that comes normally from a self-report questionnaire. Sometimes those questionnaires contain particular questions that may be more objectively observable. For example, it could be a question on physical health versus something that's a bit more subjective by nature, such as mental health. But they always require a judgment on behalf of the person filling them in into where they fall on a particular rating scale. So this is typically done, as I said, using questionnaires, and because we're researchers and scientists have historically liked to use fancy words to make themselves sound more important, they're often called measures or instruments or tools rather than questionnaires. But when I use that term, if we use that term in this presentation, or you see it written anywhere or used anywhere, they're normally just talking about what we know to be questionnaires. The first thing to point out really is that, as I'm sure you're all aware, there's just loads and loads of questionnaires out there developed across different fields by different people in different institutions with different populations, different uses. There's lots and lots. So one of the difficulty we have as researchers and as clinicians and as people that use questionnaires in the health sphere is to know what to use. So the questionnaires may differ, for example, in terms of their style and the content, what they're measuring and how they measure it, their length and the burden that someone may have in filling it in, the context and population of use. So is it for a particular health condition, or is it meant to be used more broadly? Is it for use in, for example, in a clinical trial and evaluation? Is it for use for feedback in a clinic or in a consultation to aid clinical decision making? They all differ in some way. And we make a broad classification, so we can classify questionnaires into whether they're generic, so that would mean that they're designed to measure health across different health conditions and in the general population, or are they condition specific, so if they've been developed in a particular population for a particular reason. I'm just going to give you two examples of questionnaires that have been developed in ScHARR for use in children and young people. And one of those is going to be generic and one condition specific. So the first example is the generic example. So this is the Child Health Utility Questionnaire, 9-dimension, or CHU9D. So this was developed some time ago now in ScHARR by Catherine Stevens and her colleagues. And the key thing about this measure, and one of the things that we specialize in ScHARR, is that it's got the associated utility or preference weights, and Donna will explain what that terminology means in a minute. But it has those associated things, which means that it can be used in cost effectiveness analysis and for economic evaluation. And a lot of the questionnaires we develop in ScHARR have that particular element. It's one of the areas where ScHARR is particularly strong. So this questionnaire was developed with interviews for over 70 children with a wide range of health problems, and then refined over time with input from school children and children with health conditions currently in hospital. It's suitable for 7 to 17-year-olds. It's designed to be self-completed, and as you can see, the 9D in the name means there's 9 questions or 9 dimensions of health, and these range for things like worried, pain, all the way through to being tired and your sleep. So lots of different things that this questionnaire picks up on. It's licensed by the University of Sheffield. It's been translated into lots of different languages, and it's available for use in research studies. Moving forward to a condition-specific example. So this was one that I was involved in with Donna and Jill Carlton and other collaborators in ScHARR, the DMD qual. So this was designed specifically to measure health-related quality of life in Duchenne muscular dystrophy. And again, a similar sort of development process to the CHU9D. So it was developed from interviews with people that were living with Duchenne, and then refined over time with input from more patients in terms of the quantitative performance of the questionnaire and from insight from caregivers and clinicians. This is again suitable for 7 years upwards, with 7 to 10-year-olds using a proxy version, and the rest having either a self-completion or a proxy version of completion. And it has 14 questions, although there's a reduced version with 8 questions that's used for economic analysis, and it covers similar things to the CHU9D, although it's specialised and been developed to be targeted for Duchenne, and that's licensed by Oxford Outcomes, and again has been translated into lots of different languages and is available for use in research studies. So one of the key questions people ask themselves is that if they want to use a questionnaire, if they want to measure health, is which one am I going to use? And the key thing really to identify the pool of questionnaires you may look at is to identify the what, where and who of your research or your application. So the what is what do you want to measure? So this is the construct or the constructs of interest. So do you want to measure, for example, quality of life? What's your theoretical framework for quality of life? What attributes, what concepts do you want to be captured? You know, for the DMD qual, for example, we were looking at capturing elements of physical, psychological, and social functioning. So that those would be the three key constructs of interest that we want the questionnaire to capture. The next key question is around where and what context. So a questionnaire that's developed and used, for example, in clinical trials is very different to one that would be useful for a clinician. They just demand different sets of information. So it's key to identify what context you'd want the questionnaire to be used. The last key question is who. So of course the population of interest, and in this talk we're going to be looking at the issues relevant to children. So that narrows down the playing field for the available measures that you may use in that case. But you know, you need to consider whether you, for example, want to measure health across broad groups of people or specific condition groups, and use that information to essentially narrow down your search. And when you've answered those questions, it's essentially then looking at the evidence that's available for those questionnaires to support your decision making. So we suggest that you compare your options using at least 3 criteria. So the first one's the measurement properties. So that's what evidences are available on the validity and reliability of the questionnaire. Look at that and see how questionnaires are performing. The second key issue is it acceptable for your target population in terms of length, and acceptability in terms of content. So is it going to be too burdensome for them, for example? This is particularly the case in certain health conditions where people may be fatigued or have potentially problems using their limbs or filling in questionnaires and require aids to do this. And obviously there's practical considerations as well. Is the questionnaire available? Is it in the language that you want it to be? Language version validated? Are there resource and cost implications to consider? And all of these things should feed into your decision-making process in selecting a questionnaire. So one of the key frameworks we use in terms of evaluating the measurement properties of a questionnaire is the COSMIN Framework. It's quite a thorough framework. It's quite detailed. It's essentially a set of consensus standards that have been developed by international experts, psychometricians, healthcare workers, qualitative researchers, practitioners, all kinds of people that were fed into the decision-making process on defining aspects of validity and reliability that were deemed to be important, and how we could assess these and the standards we could assess them against. And it provides a structured framework for essentially looking at the questionnaire, looking what evidence is published and whether that's positive or negative, and the strength of that evidence. But one thing to point out is that it's only the available evidence that's evaluated. So there may be a new questionnaire that doesn't have much evidence yet that you may think is worth potentially using in your situation, that wouldn't score very highly on COSMIN because there's not much evidence there. And it may be that you could then look at carrying out your own pilot studies to use the measure or find out more about it. So I just wanted to cover, before we go into the key issues that are relevant to children and adolescents, just to cover the key stages that we have in developing a questionnaire, which is pretty tried and tested format. It's used by most researchers now, the way that the questionnaire design is done these days. I'm just going to talk through briefly the first 2 elements. So how we get our items, which is a fancy word for question, and how we then select between our long list or draft items, and then item number 3, the economic valuation, Donna is going to cover in the next section. So in terms of the questionnaire generations, there's 2 main sources of evidence for this. So one of them is reviewing the literature around the constructs of interest that you're interested in, and also looking at other measures that are available. Well, one of the key cornerstones of questionnaire development and question generation is to actually speak to your target population. And we do this using semi-structured interviews with them. And then we use basically those interviews, we analyze them using qualitative analysis, identify themes that we think are important to the construct of interest that we're looking to measure. And we use those themes then alongside rules of developing questions, which are largely common sense. You know, the language of things, don't use jargon, don't use double negatives. Make sure you're asking about one thing in the question, not two things, so you can't be sure what people are responding to. Those sorts of things to derive a draft list of questions along. And we do this in collaborative teams, essentially in research teams, with ideally with stakeholder and patient input. And then once we've got our draft set of questionnaires, we move on to this process of selection and refinement. And again, we use a number of different sources here. So we use what's known as cognitive interviewing, which essentially is just interviewing your target population to get their input on your draft set of questions. And we ask them whether they're relevant, whether they're understood as intended, and whether anything's missing at that point. Is there anything we should be asking about here to measure our construct of interest that we're not? We also test them out quantitatively using psychometric techniques and item response theory analysis. And we can include other sources of evidence to this as well. So we may consult with stakeholders further based on our draft list. We may get a translatability assessment on our questions undertaken. And we essentially then bring all these sources of evidence together in a decision-making meeting with the research team and potentially other stakeholders to decide which questions should be retained in the final measure. I've just put there that sort of similar techniques may be used in adapting questionnaires, so you don't always need to develop one from scratch. It's quite possible that you may see a questionnaire that could be valid and you want to use it to measure health and health-related quality of life, but you need to repurpose it or adapt it to a new population, and it should be tested for its validity and reliability in the new population. So we're now on to the bit that you're probably most interested in, which is around the key issues that exist for measuring health and health-related quality of life in children and adolescents. I think I'm going to go through a number of these, and there may be more, so I'm not saying that this is completely exhaustive, but Donna and I identified the ones that we thought were most pertinent to us and the things that we've experienced. So one of the key issues is who should complete the questionnaire, so who should make that subjective judgment around the health and quality of life of children and adolescents. We can broadly classify responses on a questionnaire into three categories. So whether they're self-report, assisted self-report, which should be where the participant themselves is given the answer, but someone's present to help them complete it. And then a proxy report, which is where someone answers on the patient's behalf. So if it's a child, it's quite common when you're measuring the health in children and adolescents, particularly young children, that you end up with more kind of report. It's more like parent-driven questionnaire responses. So there's no sort of gold standard here, but I think that the general consensus within the research community is that you prefer to get the person's self-report wherever possible, because they're the one that's living through this health experience, so they then should have most insight into it. But then we're faced with the question of when can children reliably report on their own health, and it varies. So here are some of the ages that have been given in the literature. So there's a review by Lucy Coombs and colleagues that says they can't do it under 5. For the TUNE-ID development, it was from 7 years plus. From our work on the DMD qual, we found our participants from 7 to 10 struggled with completing a questionnaire to the point where they hadn't done it before. So it wasn't just the content of our questionnaire, but it was the fact that it was, you know, what is this? What is a questionnaire? I've never done this before. So the actual act of self-reporting on any questionnaire was alien to them. So our recommendation at this stage is that although we should aim for self-report wherever possible, you must find evidence to support the age cutoff that you're applying. And this is largely, this is a good opportunity to be done when you're testing the draft items at cognitive interviewing stage. The next key issue is around children, and it's related to the age thing, is around understanding and also the motivation and the burden of completing questionnaires. Will the child and adolescent actually want to complete the measure of health? So you need to obviously check that, especially if it's self-report, the child filling it in understands everything, understands all of the questionnaire content. So it's not just the questions, but also the instructions, the response options, what you're meant to do. And another thing to consider is obviously the response format and the burden. So is it too long, given the child's age, is it too long for them to complete? Will they lose attention? Will your data suffer at the end? There's some evidence in the literature, for example, that engaging children with a computerized format of administration is preferred to traditional pen and paper methods of administrations of questionnaires. So I think our recommendation for this is that you obviously avoid anything that's not child friendly. You need to make sure your language is suitable for the age that you'll be administering the questionnaires. But always, as we're going to be repeating throughout this talk, you need to test the understanding, test the response format and the perceived burden with the questionnaire before you administer it. The third key issue is around recall. There is actually quite limited evidence on recall, specifically health measures in children. So our common sense says obviously that recall would be better in young adults than children, and this is generally true, although there are some exceptions to this. A few studies in sort of 2017, 2015 showed that certain forms of memory that children were better at, those involving similarity rather than categorization, for example. Although in the sphere that we're working in measuring health and the kind of questions we ask, we sort of take as a starting point that children are going to have a harder time recalling over longer periods than adults. So the Lucy Coombs review recommends a very short recall period for those under 8 years, and that recall for 7 to 14 days seems okay from 8 years onwards. So if the questionnaire involves self-report for less than 8 years, I think you need to take particular consideration of the recall period here. But it's obviously goes without saying that it needs to be tailored to the particular domains you're asking and what evidence is available at the time. Another key issue is the response format of the questionnaire. So this, when I was talking about response format, I'm talking about the choices that people get when they respond. So one of the key threads here to take away is that children tend to dichotomize more than adults. So what I mean by this is they tend to be less granular, they tend to be more black and white, they tend to use the two extreme scales rather than any of the more the more detail that you find in using larger response scales, so ones that have more response choices. So there's some evidence that 3-point scales would perform better than 5-point scales for those that are aged 8 to 18. And the Coombs et al. Have recommended dichotomous, so yes, no, or on-off responses for 5 to 7 years. So current recommendations are to essentially use less response options wherever possible, but it's always possible to test this when you're doing pilot studies or interviewing your population prior to administration, just to test whether certain things perform better than others. And psychometric surveys are obviously the gold standard of looking at how people respond to questionnaires on different response scales. The penultimate issue I want to raise is change over time. So this really knuckles down into whether you're using one questionnaire to measure health across all childhood, or whether that you recognize that there's significant developmental differences throughout childhood that mean quality of life, or that what matters in health and quality of life may change over the course of childhood, and in which case there's some argument that you may need to use different versions of questionnaires to pick up different things as children age. Now this depends on your goal of your study and what you're trying to do. So for economic evaluation, for example, it's very, very tricky and complex if you're changing the content of questionnaires as children get older. So it can be beneficial in that case to identify what's common, what quality of life elements are common across all of childhood that we can measure and then use to inform economic evaluation. But it just needs to be tailored to the specific context and purpose of use, because there's arguments on either side for whether we should use age-specific versions or a consistent one across childhood. And the final key issue that I wanted to mention before we move forward onto Donna's half of the talk is just the ethics of it all. So are there any questions that you wouldn't ask kids that you may think it's okay to ask adults about their health? And I just want to caution here that I think there's always a tendency of people to jump on the more conservative side of things, to think that we shouldn't ask children about particular because they're ethically problematic. But we need to balance these against the growing children. Look at, for example, United Nations, one of the children should have a say in decisions that affect them, and to a degree it's not too different here. So it's a reason why we prioritize self-report wherever possible, that children, whoever that you're measuring the health about, or the decisions may be made about, or the economic analysis may have impacts for, should have a say in that process as much as possible. So while I acknowledge that there are ethical concerns and things that you may not want to ask children and adolescents, I think there's a balance to be struck there with the empowerment of them too, and always seek ethical approval, obviously, before you do any of this kind of research. Right, so this is my final slide. Just quick nod. That's my son there, looking very happy about a year ago. So what I've not covered in this talk, and I don't think Donna will either, is measuring health in very young kids. When we talk about very young kids, we're talking effectively from birth to, through toddlerhood to essentially preschool. Questionnaires do exist that aim to do this. As you may imagine, they're all proxy reported, so it's all the parent. And they can assess things like how active the child is, whether their behavior is typical, whether they seem to be exhibiting pain or discomfort. And there are places, for example, the review I've put on that slide, you can go to if you want to find out more about this. It's questionable to the extent they're measuring sort of health in the child versus the parent themselves and the proxy, but it's a key area that if you are interested in, there's more out there. But that's me done, and I'll hand over to Donna now. Thanks.
Thanks, Bill, and thanks everyone for coming along today. We really appreciate it. And as Andy's just said in the chat, if you've got any questions, please feel free to post them in the chat if you just put Q first. So obviously Phil's just talked about the whole issues around measuring health of children and adolescents, but I'm going to be thinking about the next stage of thinking about, well, once we've completed those questionnaires, we've completed our measure and we've got a record of the child's health, what are we going to do with it next? Well, be thinking about trying to get a score for that person's health, for the child's health, or if it's proxy reported by their parent or guardian, for example, we're going to be getting some kind of score. Well, what do we want from that score? Well, if we think about, I'm a health economist, what I would like from that score is I'd like to think about, well, how is the health of that child changing over time? So what's happening to the health of a child? Is it, for example, increasing, or is it reducing? Is it deteriorating? We want to think about what's happening. But as health economists, what we also want to know is we want to think about, well, maybe if we look at health across different conditions, say, for example, diabetes, cancer, how do these conditions impact on the health of the child? We know that they're going to impact on them differently, but we want to think about, well, how do they impact on them, and how can we generate a score that enables us to capture that? We may think about different populations. So obviously today we're focusing very much on children, but obviously we have adults, we have older adults, we have all different kinds of populations as well. We can also think about, well, we may well want to capture the health or health difference across different healthcare providers. If we want to capture, for example, the quality or the efficiency of different healthcare providers, such as different hospitals or different GP surgeries, for example. And we can all think about treatments. So say, for example, within a condition, I want to think about, well, if we've got different treatments that are available or that could be made available, how can we assess how well they work if we want to capture the impact on someone's health? Maybe by able to get this score of health, maybe it can do that. But if we think about how we might want to generate that score, well, we come across a few different problems. As Phil's just outlined, when we're thinking about a questionnaire or measure of someone's health, then we know that it has lots of different aspects within it. We call them dimensions. But we have these different aspects of health. Say, for example, we might have pain, we might have sleep, we might have mobility or ability to walk about. So what are we going to do along those lines? If we know that someone's health over time is changing, such as their pain is improving, but actually their sleep and their mobility are worsening, then what can we conclude overall around the health of that person? Has their health actually improved? Has it deteriorated? Has it remained the same? Because we've had improvements in some aspects and we've had a deterioration in other aspects, for example. What about if we want to compare across different treatments? What if some of them improve some aspects of health, but due to side effects actually have a negative effect on other aspects of health? Overall, is the impact of that treatment positive, or is it more negative, or maybe just a negligible impact? How can we get that if we're not creating a score that enables us to summarise across the different aspects of health, across the different dimensions? Well, if we think about generating that score, well, what could we do? Well, we could add them all together. So we could simply say, for example, we've got that TU9D measure that Phil talked about earlier. We could say, well, we've got these 9 questions, we've got these 9 items. We could simply score each of those and we could sum them together to get a single score, and that would work. We could then say whether health had improved over time, deteriorated over time, whether it was better or worse across different treatments, for example. But if we do that, well, actually what that's implying is it's implying a few different things. The first thing it's implying is saying, well, each aspect of health is equally important because we're giving them equal weight. So say if we've got items or questions around, say, sleep and pain and ability to move, to walk about, then by totaling all of those together and giving them an equal weight, just giving them that straightforward score, would imply that all of these are equally important for someone's health. And we may not actually want to make that. It's also very dependent on the questions that are included in the measure. And there may well be several questions, for example, on one aspect of health, very few questions on other aspects of health. And although we could create domain scores or dimension scores across the different aspects and combine them, it's still making that simplified assumption that we're assuming that everything is equally important in terms of its impact on our health. We can also make another query of thinking about, with the other assumption that we're making, is we're assuming about the different ways that people can record their health is equally important. So say, for example, if we ask about someone's pain, we could give them 3 different options where we say, do you have pain today? Well, I have no problems, some problems, severe problems. Well, if we're creating that score where we sum together across all of the questions that we've asked, we could say that no problems is worth 1, some problems is worth 2, severe problems is worth 3. But that's assuming that the distance between no problems and some problems is the same as the distance between some problems and severe problems in terms of how it impacts on our underlying health, when it impacts on the health of that child. And we may not think that that's an assumption that we want to make. We also might not want to think that that's an assumption we want to make across all of the different aspects of health that we're looking at, because we may well think that some of them actually work differently across different aspects of health that we're asking. So this is where we start thinking about, well, maybe we don't just simply want to score our health. Maybe we want to value our health. Maybe what we want to do is assign a value to it that reflects the underlying health of the person, that actually says how good or how bad that health state is, that health that that person's experiencing. And what we can do is, for every time a person can questionnaire, for every respond to that questionnaire, we can actually give them what we'd call a value. And that value reflects how good or bad we think that health state is, given all of the aspects of health that they're experiencing. And what we're doing by creating that we're thinking about how we weight the different aspects of health relative to each other, so the pain relative to the sleep, relative to the ability to walking about, but also relative to the different response options. So we're thinking about from having no problems to some problems, so from some problems to extreme problems. We're thinking about that as well. We can weight each of those differently across each of the different aspects of health, and we can have different distance between them. So what we do is we generate a single score, or we'd call it a single utility value, that would, for each combination of responses to our questionnaire, would give us that health state, that description of that person's health, and then we'd give it a utility value. And the way that we do that is by saying, well, the best health state that we can have, which is full health, would be given a value of 1, and we'd give a value of 0 for a health state that would equivalent to being dead. But we may well have health states that are so bad that they're worse than being dead, and therefore then they would have a value below 0, so they have a value, say, of minus 0.5, and we would typically expect that the lowest value you would give would be -1. We do normally constrain it at -1, but we're having that value where it allows us to give a value to that person's health where it reflects how good or how bad that health state is. Thinking about what it might look like. So these are some examples. So Phil earlier mentioned the TU90, which is this generic measure. It can be used across lots of different conditions, and it's designed specifically for children and adolescents. And it was developed using input from children and adolescents as well to tell us about what it was that's important when Catherine Stevens, as instrument developer, developed the measure. We've got a blue health state and a green health state. If we take the blue health state first, by this health state, we've got a description of a person's health where it's saying how they feel. So they feel a little bit worried, they feel a little bit sad, and it goes through those 9 aspects of health, those dimensions, and gives a severity level for each of those. When this was valued in the Netherlands, this had a value of nearly 0.8, and when it was valued in the UK, it had a value of nearly 0.7. So we can see, first of all, that this is a health state that's close to full health because it's 0.8, 0.7, and 1 was the best value that we could give. But we can see that there's differences between the Netherlands and the UK. When we look at the green health state, this is a different health state and is actually the worst health state that's described by the TU90. So this is where you have, say, for example, you feel very worried, you feel very all the way through to you can join in with no activities. And when that was valued in the Netherlands, that had a value of minus 0.5, and when it was valued in the UK, it had a much higher value of 0.3. Now, there's a few things going on here. The first is that we would expect, if we ask for preferences within a different country, that we would expect people to value health states differently, because we know there are cultural differences, for example, in how people value these health states. But equally here, we used a different task when we were asking people about how good or how bad they think different health states are, and we know that that will have had an impact as well. So we're carrying on thinking through some of these issues in my next slides. So we're thinking about, well, just making sure why we want to value health. If we're going back to some of the arguments that I made earlier, well, if we're thinking about this value that we've given, well, what it gives us is that single number. And when we were thinking as a health economist what we might want to do with those values, well, we might want to look at how health changes over time. And we can do that if we have that single value for that person that we can see over time. And we can average across individuals to be able to look at general patterns. We can compare health across different conditions using those values. We can compare across different populations. We can compare across those different healthcare providers. And for assessing the value of new treatments, we can also look at the value different treatments provide and compare across them. So we can see, well, if we're thinking about allocating resources in a healthcare system, for example, NHS, then we can use that information to be able to see how to best allocate the resources in that healthcare system. But if we think about, well, the way that we know that treatments, for example, impact on on people, it's not simply that they impact on the underlying health of the person. They can also extend length of life. They can also lead to a life extension. So what we actually do with these values is we multiply them by years of life, and it gives us something called a QALY, a quality adjusted life. What that is it's a metric that we can use to be able to capture the impact of treatments, where they may impact on our underlying health, they may impact on the length of life in the future, how long we live, and we can also capture that they may impact on both. And it's a very useful metric to be enable us to look at the value therefore of different treatments. And those that, for example, that improve the aspects of health that have the largest weights, pain quite often gets a large weight. Improve someone's pain, then actually it will generate quite a large benefit in terms of their improvement in their quality of life. So how do we obtain those values? How do we get those values? Actually, what we do is we tend to use a value set that's available so that every time that questionnaire is used, you can simply use the values that have already been obtained. And so every study then that uses the different questionnaires can use those same values. They're off the shelf, they're already available. You don't need to include anything extra study. So that enables us to have comparability across different studies. And because we know that different countries can give different preferences, we'd have different value sets across different countries. So how do we do those values? Well, what we actually do is we ask people to complete some tasks thinking about how good or how bad they think different health states are. We can't possibly ask them to look at every single health state that's described by a questionnaire because there are literally thousands. But what we can do is look at a subset of those, and then we can use statistical modelling to be able to generate what we would call a value set, which enables us to generate that value for every possible combination responses that a person gives us when they respond to that questionnaire. So we're thinking a little bit more, well, if we want to think about asking people to complete those tasks about how good or how bad different health states are, well, what do we do? How do we make those decisions? And we're thinking back to some of those normative decisions that Phil was thinking about earlier. We're thinking, well, what kind of decisions do we need to make to be able to think about this? Well, who should we ask? Whose values should we think about? When we think about adult health states, then typically we ask adults, but for children and adolescents, this is a lot less straightforward. Whose values should we be thinking about? Should we be thinking about the adolescents or children who may be in those health states? Should we think about the children and adolescents who could experience those health states in the future? Should we think about adults, for example? Should we think about decision makers? How should we ask the questions? Which tasks should we use? And also, who should we get to imagine who's living in those health states? Should you be imagining you? Should you be imagining someone else in those health states? How should we think about conceptualizing those issues? If we're thinking about whose values we should ask, I'm sorry, some of the symbols appear to have changed. They were ticks and crosses on my version, but they've changed into some other symbols. Sorry about that. If we're thinking about whose values we ask, well, if we're thinking about adults, well, you can make the argument for adults on the basis that they're taxpayers and they're eligible to vote, and that's how we get the funding for the healthcare system, is via tax, and that's how we vote in our government, is by the voting system. So maybe we should give them the power. But the adults don't fully understand the health status experienced by children and adolescents. They can't possibly understand what it's like for a child and adolescent to experience those states of ill health. So if we're thinking about adolescents, well, maybe they're the better population that we should be asking to think about saying how good or how bad different health states are, because it's going to be adolescents and children that are in those health states, and arguably they'd be able to better understand the impact of those health states on lives of themselves or lives of people, their peers. However, and also we can make the same arguments, going back to Phil's arguments before about empowering adolescents in being able to say their views about things that matter for them. There's a lot of arguments where we can say, well, actually we should involve adolescents in this, because those values are going to be used to actually ultimately potentially determine which treatments are made available. Then being able to empower adolescents within that decision-making process seems really important. But there's some practical issues around whether they can meaningfully complete tasks, and some further issues around ethical concerns, because if you remember back to when I was saying about those values, that value of 1 is full health and that value of 0 is dead. So if we want to attain those values, whenever we ask those questions to get those values, we have to make mention of dead. And there may well be important ethical concerns around mentioning dead to adolescents, because it may well cause distress. Should we ask both? Should we ask adults and adolescents to complete the valuation tasks? Because then we're getting both those that are funding the healthcare system, but we're also getting those people who may well be experiencing those health states and the population being used for the assessment of the treatment. So maybe we should ask both. But then we're also thinking about, well, how do we decide who we ask? Should we ask decision makers? Should we ask adults or adolescents who they think we should ask? Well, this all becomes quite a tricky situation. If we're thinking about what kind of tasks we want to ask, well, the problem that arises if we want to ask adolescents is a lot of the time the tasks that have been asked of them tend to be ordinal tasks. So thinking about those blue and green health states that I showed a few minutes ago, we could give them that blue health state and say which is the best part of that health state, which is the worst part of that health state. And it's fine to do that, and we know that it works well, and we know that they understand the task, they can meaningfully complete the kind of tasks. But if what we really want to know is how that health state relates to dead, so that we can find out where it is on that 1 to 0 to -1 scale, well, that's not going to do that. However, I think there are some points, and as Phil was saying before, I think what we've got to think carefully about is actually not being scared to ask the question about whether we could administer tasks that make mention of dead to adolescents if it was appropriate with ethics approval and very sensitively done, but maybe need to think about whether it is appropriate to questions. If we think about adults, well, actually the most commonly used task that we use for adults is where we ask them to sacrifice years of their life to avoid ill health. So we actually say, are you prepared to live a shorter length of life to avoid this bad health state, this impaired health state? And we know that actually adults are quite happy to do that. At least a lot of adults find that task an appropriate task to do, and they provide answers to it, but they can respond a little bit differently if they think maybe a child's living in that health state. So this begs the question that if we are asking adults because we know they can meaningfully complete the tasks, we can also ask them the kind of questions where we're thinking about where the health state lies relative to dead. Well, if they're imagining themselves in that health state, which is actually what we do when we're thinking about adult health states, we ask adults to imagine themselves in that health state, so it's hypothetical, they're thinking about how they would feel in that situation. Then we know that when we ask adults to imagine themselves in that health state, then they can answer those kind of questions, and they would be willing to trade years of their life to avoid ill health, particularly very severe ill health. When we think about the child questionnaires, so the 29D questionnaire that I showed you earlier, well, that has some items that, for example, mention daily activities, and another that mentions schoolwork. Well, my daily activities as an adult are going to be different to a daily activities of my child. So I know that I would automatically think differently if I was looking at a health state that was asking me to imagine those daily activities. And what do we do if we've got such as a dimension such as schoolwork, which obviously doesn't exist for adults? And if we change it to work, for example, then that's not appropriate for older adults who wouldn't have work, or for people who don't work. So we can soon come into some problems. So we could ask adults to think about a child, say, in the context of a 10-year-old child. So they're thinking about a child, and so they're responding, thinking in the context of a 10-year-old child. So that's a distinction in the sense that not now asking to think about imagining themselves, they're thinking about somebody else, and that somebody else is a child. You know that when we ask that question, actually, in general, people tend to be less willing to sacrifice years of life to avoid the ill health. So they're less prepared to say that the child should die sooner to avoid the health when you ask them the equivalent question about their own health. And what we don't know is who in particular is imagined, and different people will imagine different children. They may imagine, for example, a child that they don't know, or they may think about their own child, and this may mean that they actually answer the question differently dependent on who they think about. And people do, we also have found in research that Phil and I have done very recently, we found that people do seem to think that ill health does impact differently on the life of a child than it would on their own health. So it's not just that people provide different responses based on being less willing to trade, it's also that they think how a health state description impacts on the life of a child is actually different to how it impacts on the life of themselves. So as my final point, we're just thinking about, well, actually, why does this matter? Why is all this important? Why are the methodological issues that we're thinking about how to measure, how to value child health? Why is this important? Well, this is a really simplistic example, but it's to try and indicate why this is important. So we know that if we ask adults to think about children in the health states rather than themselves in the health states, they tend to give higher values. So say that they give a value of 0.8 when they were imagining a child and 0.7 when they valued for themselves. We also know that it can impact on the range of possible values. So that essentially means for that worst possible health state, it's actually higher. It's not as low as it would be if they were answering for themselves. So the range of values might be smaller. So my example that I've put at the bottom, what this tries to get across is this may have a different impact, and it may impact differently depending on whether the treatment affects your health or whether it affects how long you live, affects your life expectancy. So say, for example, we've got that 0.7 or the 0.8. If we have a life extension of 10 years, then the benefit that we get of those extra 10 years, if we give the value of 0.7, would give us an extra 7. We call them QALYs, but it's an extra 7 units, if you like. But if we given it at 0.8, then the benefit that we got from that treatment would have been higher at 8 QALYs or 8 units. So it would have been higher than the 7. So it does seem that it matters. But it can also matter differently dependent on whether that improvement is in terms of your underlying health. So say, for example, an improvement in our health from 0.6 to 0.8, so that would be an improvement of 0.2. If we'd have had an improvement from 0.4 to 0.7, which would have been the case if we'd have asked the people to value health states for themselves, we'd have had a larger gain, so it would have been a 0.3 gain across those 10 years, and then the benefits would have been larger, so the benefit would have been 2 or 3. Actually, the benefits there would have been larger when we'd asked them to value the health states for themselves. So there's a bit of a contradiction. When we ask them to value the health states in different methods, it impacts on the values that they use, but this also impacts on how much benefit it shows that different treatments apply, and the way that it generates it can be different depending on whether the treatment affects our health or extends our life, or whether it's a little bit of both. So that's why it's important that we address these issues appropriately. And we can also focus very much there on children, but if we think about when we're allocating resources in the NHS, for example, we're also making those decisions across different populations, across children and adults, for example, and that can also become more important as well, because we're measuring it differently, for example, for children and adults. So hopefully, this is my last slide, thinking about what we've been discussing today, we've looked at the fact that measuring and valuing health of children is quite a complex issue, but there's a lot of emerging research that's looking at this in recent years, and there's a lot of emerging evidence in the last few years on this very important issue. But one thing I wanted to think, to bringing this to a close, is that as much as researchers like Phil and I do a lot of work in the area thinking about the methods and trying to make the methods better, this can only impact on decision making and upon the allocation of resources if actually we collect data about child health. Because if we don't collect that data about child health, then no matter how much we improve the methods, this isn't going to enable better decision making. So will there be an emerging evidence base that's going to match the methods research that's been undertaken? And then we're happy to take some questions. I can now look at the chat. Apologies, I haven't been looking at the chat before.
Okay, hi Donna, can you hear me?
Yeah.
Yeah, I think Phil has answered most of the questions in the chat. There were quite a lot. There is one from Joseph though that I don't think Phil responded to. And Joseph asks, this was to do with the societal weighting. He says, if the instrument is filled out by individual children, but societal weights are applied, is the health utility still capturing children's subjective dimensions of health?
If weights are from adults, then I guess my argument would be is that it's adult preferences that have informed it rather than the child's subjective views around it. So I think if we want to think about the child preferences, I mean, one that I didn't touch on in in the talk is that actually children find these tasks typically too difficult to be able to meaningfully complete. So it does tend to be adolescents rather than children. But if we want to think about how children weight the different dimensions of health, then we'd want to ask adolescents about their values rather than adults to be able to get those weights.
There's just another outstanding question from Marissa, Donna. I've just posted it in the chat. So is there any tools that we know of that have been used, validated in the very young to generate utilities?
Not that I'm fully aware of. I think the problem that it faces, Marissa, is that when we're thinking about the very young, if we want to think about utility values, it can become quite difficult, because with the utility values, they assign obviously a value to the health state, but if we know the health state would be different for children of different ages anyway, say for example mobility, if you're asking a child of 6 months a question about mobility, you get different responses for a child who is within a normal range relative to their peers. You can get different responses at different ages, and it will change very rapidly within those really young years. So I think that's why it becomes very difficult with utilities, because it's comparing across sort of the differences between expected for that age. So I think Joseph has just posted something in around the Tandy around that, but I think some of the options that I think people are exploring for very young ages is maybe thinking about something slightly different. If we're thinking about cost effectiveness modelling, they think about using something slightly different for children that are very young, rather than using sort of the preference-based measures, rather than using a questionnaire. So sorry, I can see there's just another question from Adam. What's the NICE guidance of which quality of life measure is preferred for children and depends on age group? For children, actually, NICE, there is no preferred measure currently. So the current NICE guidance that still exists at the moment doesn't have a preference. And when NICE went out to consult at the end of 2020 on their new guidance, that didn't make a recommendation either. So NICE currently don't have a preferred measure for children. Are there any more questions?
Anil, do you want to ask your question now? Are you there? Can you switch your mic on if you want to ask your question, Anil? Can you hear me? Donna, can you hear me?
I can, Claire.
Yeah.
Okay, I don't know, maybe Anil has gone. I know he did have his hand raised. I thought he wanted to answer a question using his mic.
Hi, Neil, can you hear us?
Feel free to type it in the chat if you can't unmute yourself at present. Okay.
Sorry, I can see that Anil has asked a question, but it gone into the private chat. I'll read it out. It says, what is the best time to ask these questions, before school time or after or during weekends? So is there an optimum time to use these instruments with children?
I don't think that we've done much research into this, and I'm not sure that there would be much out there. It depends normally on the context in which they're used. So it comes much more within study design and you know, considerations, for example, around particular health groups that you may be using these questionnaires with, and how, for example, symptoms vary over time in terms of burden and what suits people differently. So I don't think there will ever be a one-size-fits-all for this. I think it really depends on the study or trial or clinical application of interest.
Okay, thanks for that, Phil. It looks like there's another question from Joseph. He says, we tend to use health utility, health status, and health-related quality of life interchangeably, but strictly speaking, health-related quality of life needs to capture individual perception. If societal weights are applied, are health utilities still health-related quality of life?
Donna, you've just typed.
Yeah, I can see you've replied in the chat.
Yeah, I've just responded, Joseph. Yeah, I think Joseph's one of our PhD students. So I was going to say, I think John Brazier and Creamy have written some papers that have been looking at the distinctions of between health utility, health-related quality of life, and some of the differences in language and how we can mean it and so forth, which probably doesn't fully answer your question. But I guess I just try and distinguish between the measurement side, where we can still ask them about their perception around what they think their health state is today, but the utility is, if you like, we're using those for a different purpose. And obviously today I've been focusing a bit more around that we're using them to assess trade treatments, for example, but quite often it's that we're using this weight for a reason, and I wouldn't want to interpret them always as being reflective at an individual level. It's more that we're using those scores for a different purpose.
Okay, thanks for that, Donna. So I think if that is all of the questions,